How's it going, guys? Easy question for renal slash physiology for step one. This style question right here is all over the NBME exams, okay? This exact style. They really want you to know this specific concept, okay? It's short and to the point. This is not going to be a long clip. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. The links are down below. Now I'll start the clip. 68-year-old man, 4-day history of pain with urination. He has history of depression and takes amitriptyline. Physical examination demonstrates a suprapubic mass. Serum creatinine is elevated at 1.6 milligrams per deciliter, normal range 0.7 to 1.2. Question wants to know the most likely explanation for this patient's creatinine. So the 4-day history of pain on urination, the suprapubic mass, this is a distended bladder that he has due to BPH. And this is really high yield for USMLE. They will not give you symptoms necessarily. You just need to assume that all old men are going to have some degree of BPH. Okay, they don't have to say urinary hesitancy, dribbling. They don't have to mention any of those findings. Now, amitriptyline, a TCA, which can be used for depression, can be used for painful peripheral neuropathy in diabetes, as an example. Amitriptyline is a high-yield anticholinergic. Okay, so TCAs prevent the presynaptic reuptake of serotonin and norepinephrine for antidepressive effects. However, TCAs are also heavily anticholinergic, antimuscarinic. Okay, same with antipsychotics, same with first-generation H1 blockers such as diphenhydramine. But when you give an anticholinergic, which can cause urinary retention to a guy who has BPH, that combination is leading to post-renal insufficiency. Okay, that's why he has elevated creatinine here. So post-renal, BUN to creatinine ratio would be under 20 in theory, and fractional excretion of sodium would be over 1%. I've made other questions on those details in particular, but I'll stay focused here. So BPH in combination with an anticholinergic, and the question wants to know the most likely explanation for these findings. And you just need to know straight up that this is going to be increased tubular hydrostatic pressure. It's a backup pressure all the way to the renal tubules / Bowman capsule. They can sometimes have the answer as increased Bowman capsule hydrostatic pressure, increased tubular hydrostatic pressure. This exact same question shows up at least 3 to 4 times on the offline NBME content, okay, as an example. They love this style question here. Now, I should just mention real quick that hydrostatic pressure is a fluid pressure. It's an outward exerting pressure. It's due to a backup of fluid, okay? Oncotic pressure is a solute-driven pressure, usually from proteins. It's a retention pressure. So if you have high oncotic pressure, then you can retain fluid within a lumen. If you have a decreased oncotic pressure, you'll have fluid leave the lumen, okay? But oncotic is not related here. Oncotic is more seen in nephrotic syndrome, okay, when we're losing protein in the urine, when you have peripheral edema, or if you have liver failure where you have decreased production of albumin by the liver and you have peripheral edema. And hydrostatic pressure, classically edema in the setting of cardiac failure, increased hydrostatic pressure, but it's not related to this clip, right? We just need to know increased tubular hydrostatic pressure, increased Bowman capsule hydrostatic pressure is what you're going to get when you have an elevated creatinine in the setting of BPH, or in the setting of cancer in a female, classically cervical cancer, and it can be ovarian cancer where you get impingement on the ureters, and that can also cause hydronephrosis back up to the kidney. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.